Hi, my dear friends. Today I'm going to discuss with you a series of questions based on images, and all these images I have taken from the Robin Pathology, and I hope that these questions will be helpful for you. So let's start with the first question. An 80-year-old man with a long-standing diabetes and systemic hypertension dies of congestive heart failure. The luminal surface of the abdominal aorta is shown in the image. Which of the following pathological changes would you expect to see on microscopic examination? Acute inflammation of the vessel wall, bacterial colonies in the vessel wall, cystic medial necrosis, lipid deposition, and smooth muscle cell hyperplasia, or obliterative end arteritis of the vasa vasorum. So, the patient is suffering from long-standing diabetes and systemic hypertension, and he died because of congestive heart failure. So if you see that in patients with suffering from diabetes or hypertension, the vascular pathologies mainly are atherosclerosis or aortic aneurysm, or in some case of severe hypertension, we can see aortic dissection as well. So, but in this question, the patient died because of congestive heart failure. He didn't die because of some aortic aneurysm rupture, because of some aortic dissection, because there is no history like that. And they has taken the autopsy of the abdominal aorta, and the sample here is showing some areas with different color. It is not homogeneous at all. It is not hemorrhagic. It is not, there is no rupture of the aorta. We cannot see any aneurysm in this aorta. So what are the things that we can see in this aorta? So here we can see that in these areas, there are yellowish discoloration. And if you want to ask that what are these, so these are the feeding vessels to the adventitia. So if you have some idea about the if you have some idea about atherosclerosis, then we can say that in atherosclerosis, or in a condition where there is accumulation of the fat lipids into the intimal layer of the vessels, there we can see some yellowish discoloration. So all these yellowish discoloration are nothing but they are the deposition of the lipids. Then gradually these lipids are engulfed by the macrophages that are called as the lipid laden macrophages. Gradually it start to initiate a process of inflammation there, and with time it can lead to formation of aortic aneurysm. It can lead to formation of a huge block of atherosclerosis. So here a patient's aorta is showing some sort of fatty discoloration, fatty deposits into the lumen. So let's see that what about the other options. Acute inflammation of the vessel wall. It is not an acute inflammation of the vessel wall, because if there is inflammation, we can see some hemorrhagic areas. At least we can see some sort of inflammatory areas, some sort of edematous areas in this specimen. Bacterial colonies in the vessel. No, if there is bacterial colonies, then again we can see some sort of inflammatory process there. It is not a cystic medial necrosis. About the question number D, a lipid deposition and smooth muscle cell hyperplasia. Yes, it seems like the correct answer. So let's see the option E, obliterative end arteritis of the vasa vasorum. This the obliterative end arteritis, normally we can see in patient suffering from syphilis. If a patient has syphilis, then there is a infiltration of the lymphocytes around the vasa vasorum, and there is marked inflammatory areas you can see, and that can also lead to aortic aneurysm, syphilitic aneurysm, or aortic dissection. So if you want to focus here, that these black dots that we can see here, they are nothing but they are the vasa vasorum. So around the vasa vasorum there is no inflammatory area, so it is not an obliterative and arthritis of the vasa vasorum. So our answer is a lipid deposition and smooth muscle cell hyperplasia. Okay, so let's move to the next question. A 69-year-old woman presents with crushing substernal chest pain and nausea. Laboratory studies shows elevated serum level of cardiac proteins, CKMB 8.5 nanogram per ml. Troponin I is 3.5, which is increased. A diagnosis of the myocardial infarction is confirmed by ECG. Despite the treatment, the patient became hypotensive and resuscitation attempts are unsuccessful. A cross-section of the patient's right coronary artery at autopsy is shown in this image. Which of the following pathological changes are evident in this autopsy specimen? So it's not a difficult question. So they are saying themselves that a patient, he had MI and the MI was not stable. So it was an unstable MI. Okay, so now what does it mean by unstable MI? In unstable MI, what happened in the vessel, the majority of the lumen, more than 90%, more than 85 to 90%, it's occluded by the atherosclerotic plaque. If it's not like that, then what happened? There is a formation of atherosclerotic plaque, which is highly thrombotic. There is a platelet aggregation and accumulation over the plaque. So anytime the thrombotic plaque, which is formed above the atherosclerotic plaque, rupture and it occluded small vessels completely. So in that condition, despite of resuscitation and despite of giving medical treatment, sometimes the patient undergoes hypotension, MI, and that can cause the death of the patient. So in this condition, we can also see that this is a coronary artery, this is the lumen, and the lumen is occluded by, see, a thrombotic plaque and atherosclerotic plaque. So this lumen is occluded, and there was a thrombus here, and it cut off, it went forward, and it occluded the blood vessels. So let's see the options. Number first, arthritis and atherosclerosis. Yeah, it may be atherosclerosis, but it cannot be arthritis because we cannot see any inflammatory cell in this particular area. So we will rule out arthritis. Atherosclerosis and thrombosis, it seems like a correct option. Microaneurysm and canalization, no, we cannot see any outbulging or any microaneurysm in this vessel. Thrombosis and calcification, yes, it may be thrombosis but cannot be calcification because if we use certain stain that can stain calcium deposits in a bluish color, so we cannot see any blue deposits here, so we will rule out calcification. And usually in calcification there is a condition where the tunica media is calcified. In that condition there will be no narrowing of the lumen and there is a very less chance of having sudden MI or unstable MI. So we will rule out the option D also. Vasodilation and arthritis, so this is not the correct option. So our correct option is atherosclerosis and thrombosis. So atherosclerosis, a lipid deposition under the tunica intima, then there is the occlusion of the most of the lumen, and the atherosclerotic plaque it become unstable. It is highly thrombogenic, and the thrombus form above it, and that can cause occlusion of the vessels. Thank you. So next question. A 55-year-old man with a history of hypertension and type 2 diabetes is rushed to the emergency room after collapsing. He describes tearing chest pain radiating to the back. His blood pressure is 90/50 and pulse is diminished. Cardiac auscultation reveals a diastolic murmur consistent with aortic regurgitation. The ECG is normal and the blood test for the cardiac specific protein and the enzymes are negative. The patient dies within 24 hours of admission. The thoracic aorta autopsy is shown in this image. The pathogenesis of this lesion is most closely related to which of the following underlying condition: connective tissue, weakness of the aortic wall, fibrinoid necrosis and the smooth muscle hyperplasia, immune complex mediated vasculitis, neovascularization of complicated atheromatous plug, subintimal lipid deposition, and smooth muscle necrosis. So if you are unable to see the autopsy image given here, and you're unable to understand, then the question itself is giving a complete detail of the pathogen of the pathology. You can make easily a diagnosis from it's only from the symptoms only. Okay, so how you can make a diagnosis? So if you see in this question, they're saying that the patient is suffering from hypertension. Yes, a patient is suffering from diabetes. As I earlier said, that if a patient is suffering from hypertension, from diabetes, then there is a high chance of having aortic rupture, aortic aneurysm, aortic dissection, and atherosclerosis. So which of the following pathology fits in this condition or in this patient? So they're saying that a patient is suffering from hypertension and type 2 diabetes, and it's an emergency condition. Okay, and he collapsing. He describes a tearing chest pain radiating to the back. So we have studied in medicine that there are two pains usually, as I know. The one pain is there of the pancreatitis that can radiate to the back, and number second chest pain is the aortic dissection that can also radiate to the back, and it is a very very severe pain. That's why they are saying that it's the tearing chest pain that radiates to the back. So it is a thoracic pain, while pancreatitis is usually abdominal pain. So the blood pressure is also dropped down. So it's mean there is a rupture of the aortic aorta. So once there is a aortic dissection, the blood leak out into the lumen, and that can cause hypotension. The cardiac auscultation is reveals a diastolic murmur. Yeah, why there is a diastolic murmur? Because if for example this is your heart, okay, and this is your aorta, for example, okay, and this is what your aortic wall. So normally what happened, if at this area there is a rupture, or we can say there is a damage because of the hypertension, because of diabetes, because of the weakening of the aortic valve, then the blood from the lumen, it penetrates into the intima or into the vessel wall. So once it into the vessel wall, definitely there is a ballooning of or dilation of this particular area. This dilation of the vessel, can pull the aortic annular ring where the wall of the aorta is mounted. So once it pull the aortic ring, then the flap of the aorta, for example, this is the aorta, and aorta is a tricuspid, okay, like this. So once it become like this, because of the pull, it cannot completely open, completely close, sorry. Once it can't completely close, the blood which eject out during systole, it come back at the initial or the early part of the diastole. So we can hear a diastolic murmur. So they are saying that there is a diastolic murmur, and they're also saying that there is a aortic regurgitation. ECG is normal because there is no MI. Blood test for the cardiac protein or enzymes are also negative. The patient dies within 24 hours of admission. The thoracic aorta at autopsy shown in this image. So you understood that the diagnosis is a thoracic aortic aneurysm because of hypertension, because of diabetes. So they are asking that what are the other conditions that can lead to this condition. So we can see here that there is a rupture of the aorta. We can see this is the lumen. Okay, so option number 1, the connective tissue weakness of the aortic valve. Yes, it could be, because in case of the Marfan syndrome, if you know that in Marfan syndrome, we can also see there's a weakening of the vessel wall, and that can also lead to aortic rupture, aortic dissection, aortic aneurysm, and aortic ectasia or dilation. So all these conditions can see because of the weakness of connective tissues into the aortic valve. It seems like option A, it seems like correct option. Second, fibrinoid necrosis and smooth muscle hyperplasia. It is not the correct answer, because there is no necrosis, and I think the question is not indicating toward any sign like that. There is no immune complex mediated vasculitis. It is not a neovascularization. And about the subintimal lipid deposition, and usually in subintimal lipid deposition we can see a atherosclerotic plaque not aortic dissection. So our correct option is connective tissue weakness of the aortic valve. So let's go to the next. Okay. A 45-year-old woman present with a pain in the leg upon exercise and destruction of the tip of his finger. He has an 80-year history of smoking. Laboratory values include hemoglobin of 16, WBC 8500, serum cholesterol is 220 mg per deciliter, fasting glucose of 90 mg, and negative test for the anti-nuclear antibodies. Biopsy of the affected areas reveals intraluminal thrombi in the medium-sized arteries and inflammation extending from the arteries to a neighboring vein and the nerve. What is the appropriate diagnosis? So they're asking about a condition of the medium vessel vasculitis. So I will teach you a simple way or a simple method to rule out the answers to the incorrect options, and after that I'll go through the explanation of the condition. Okay, so number first one, that is they're saying that the patient has a pain upon exercise. It means that whenever the patient start to do some work, there is because of the occlusion of the artery, because of the lack of supply of the oxygen, a patient start to feel a pain, and that condition is called as claudication of pain. Okay, and the destruction of the tip, they're saying that there is a destruction. It means that there is a necrosis and there is ischemia because of the vascular problem. And here the main important thing you need to take into account is that there is a 80-year history of smoking. So this condition has some relation with that of the smoking. Everything is okay, the lab values are okay. The biopsy shows that the thrombi is not like a small thrombus. It's not like it's occluding a small portion of the lumen. It's completely occluding the whole lumen. Okay, so it's intraluminal thrombi in which type of the vessel? In a medium-sized arteries, and the inflammation that extending from the arteries to the neighboring vein and the nerves. So here we can see that this is the vessel, this is the artery, and this is the thrombi, and here we can see inflammatory cells, and this is the other WBCs, RBCs, which is forming a thrombi, and this is the vein, and the lumen is also, you can see some cell we can find, and the lumen is very near out, and these are the neurons. So they are showing that there is involvement of the artery, there is the involvement of the vein, and also there is involvement of the nerve. So what are the conditions? What are the type of the vasculitis where we can see the involvement of the neighboring areas, neighboring structures as well? And number second, what are the conditions where we can see medium-sized vasculitis? So rule out easily. Takayasu arthritis is not a medium size, is not a small, it's a large vasculitis, so we can easily rule out. Kawasaki, it could be the answer. Polyarteritis nodosa is again small vessel vasculitis. Churg-Strauss disease is also small vessel vasculitis, and usually involve the capillaries. There will be capillary hemangioma, cavernous hemangiomas we can see in Churg-Strauss disease. So we have competition between two options. Option A, Buerger disease. Option B, Kawasaki disease. So I will give you differentiation between that of the Buerger and that of the Kawasaki disease. Kawasaki disease is a medium vessel vasculitis usually seen in children less than 5 years of age, and there is a history of fever and there is no association with smoking, and it's usually involved mucosal lining as well, and there will be palmar erythema, and we can also see some non-suppurative conjunctivitis in case of Kawasaki disease. And the most important thing for the Kawasaki, usually the examiners love to give in your question, is strawberry tongue. So because of the involvement of the taste buds, because of involvement of the mucosa, there will be mucosal erythema in the mouth along with strawberry tongue. So there is no indication like that here. And again, and the most important thing, anti-nuclear antibodies are positive in case of Kawasaki disease, so it cannot be Kawasaki disease. So by ruling out all the answers, you can choose the correct option. And now define that what is the Buerger disease. So a Buerger disease is an occlusive inflammatory disease of median and small arteries of the distal arm and leg. The etiology, the role of the smoking is in etiology, and it can be because of the smoking. And if you see microscopically, the microscopic examination of the affected vessels, it shows polymorphic nuclear or the neutrophilic infiltrates that extending to the neighboring vein and the nerve. The inflammation of the endothelium is associated with thrombosis and obliteration of the affected vessels. That's why we can see in this condition there is a complete occlusion of the vessel. So I think it's clear to you now. So let's move to the next question. A 45-year-old man is brought to the emergency room with a rapid pulse and cold and clammy skin. The blood pressure is 90 by 50 mmHg, and X-ray film of the chest demonstrate dilation of the ascending aorta. Cardiac auscultation reveals a diastolic murmur in the aortic region. Laboratory studies shows that the serum cholesterol is 160, hematocrit is 35%, and hemoglobin is 13.6. The fluorescent shows that the treponemal antibody test is positive. The patient suddenly became hypotensive and dies. The luminal surface of the ascending aorta at autopsy is shown in this image. Which of the following was most likely involved in the pathogenesis of this aortic lesion? So we already discussed in our first question that there are some conditions where there will be aortic rupture, aortic aneurysm in a condition when the patient is suffering from syphilis. So here is the question. Here, if you see that the question is trying to describe the whole complications, the whole symptoms that the patient is suffering from, that there is a cold, rapid pulse, the pulse is high, it means there is a hypotension and the oxygen or the circulation is getting affected. There is no enough blood into the systemic circulation. That's why the heart is trying to pump more rapidly. Okay, and cold and clammy skin is mean there is a peripheral vasoconstriction or because of the lack of blood toward the periphery. The blood pressure is 90 by 50. It means there is a hypotension. The X-ray just demonstrated the dilation of the ascending aorta. It means there is a aortic dilatation. Okay, aortic aneurysm could be there. It could be because of the damage of the connective tissues of the aorta, because of the elasticity, loss of elasticity. There may be dilation of the aorta. And what are they saying? That there will be diastolic murmur in the aortic region. Is again the same, that once there will be dilation of the aorta, then what happen? The annular ring of the aorta is dilated, it gets stretched, and the valve cannot close properly. Once they cannot close properly, there will be a backflow of the blood, and that condition can lead to aortic regurgitation, and that can be heard on auscultation as a diastolic murmur. The lab value shows the cholesterol is normal, hematocrit is normal. So what they said that the treponema antibody test is positive. It means that the patient is suffering from syphilis. If a patient is suffering from syphilis, okay, then it means there are some conditions. Usually in case of the tertiary syphilis, there are some problems related to the aorta also. So what are the problems? The problem could be syphilitic aneurysm, the problem could be syphilitic dilation of the ascending aorta, and the problem could be syphilitic aortic dissection. Okay, so it could be maybe there is a syphilitic dilation of the aorta. Okay, so what the other findings? The patient suddenly becomes hypotensive and dies. It means there is a circulatory collapse. The luminal surface of the ascending aorta on its autopsy is shown in this image. Which of the following most likely involved in the pathogenesis of the aortic lesion? So we can see that here. Okay, let me show you the autopsy anatomy clearly. So this is what the aorta. We cut the aorta, we open the aorta, okay, and we are trying to see the luminal surface of the aorta. So these are the luminal surfaces of the aorta. So what are the black dots indicated showing here? So these black dots are nothing but they are the feeding vessels, or the we can see vasa vasorum. So these are the vasa vasorum. Okay, so these are the normal vasa vasorum which is feeding to the adventitia and 1/3 of the tunica media. And what are these then? What are these? So these are also the vasa vasorum. So these are normally should like this small dots as we can see here, but it's not like that. It's mean there is something problem with there of the vessel. So normally what happened in case of the syphilis, there is infiltration of the lymphocytes around the vasa vasorum, and there will be inflammation, there will be necrosis of the vessels. So once there will be necrosis, definitely there will be injury, there will be damage, there will be necrosis, and there will be hemorrhage, bleeding we can see in this condition. So it could be because of the syphilitic infiltration, or thus because of the syphilis, treponema pallidum, or because of the antibodies, because of the some accumulation of the lymphocytes, the inflammation start in this particular area. So that can finally leads to occlusion or the damage of the vasa vasorum. So once the vasa vasorum damages, definitely there will be no supply to there of the adventitia, the one third of the tunica media. Then definitely there is a damage from the inside as well as from the outside of the aorta. That can lead to dilation, that can also lead to aortic dissection and damage of the aorta, and as we can see in this condition. So what is this called? It is called as the end arteritis of the vasa vasorum in case of syphilis. Okay, so let's see the options. Okay, so arterial wall defect due to diabetes, no, this is not related to the diabetes because there is no history of it. Atherosclerosis, no. Congenital defect of the arterial valve, no. Cystic medial necrosis is not the answer. So our answer is endarteritis of the vasa vasorum, that can see, that can see in case of syphilis. So moving to the next one. A 38-year-old woman with a history of the ischemic heart disease present with the disfiguring skin lesions. Physical examination shows xanthomas on the dorsal surface of the both hand and xanthelismas of the eyelids. Laboratory study reveals serum cholesterol is 820 is highly elevated and significantly elevated serum triglyceride and LDL. Which of the following histological findings could be expected in the biopsy of the patient's skin lesion? So this is not a difficult question. So these are normally we can see in old age women and sometimes a patient with high cholesterol level, high triglyceride level. There is accumulation of the fat, the lipids on the areas which are slightly loose. In case of xanthelasmas, there is accumulation of the fat on the upper eyelid and the lower eyelid toward the nasal side, and in this condition we can see that there is a deposition of fat around here. Okay, so if you take a biopsy of this particular area and try to see, then definitely we can see that there are, this is your skin and here deposition of the fats. Then definitely the skin macrophages and the dendritic cells, they try to engulf these lipid deposits, and once it engulfed by the macrophages, so they are filled with macrophages with fat. So this is the nucleus and it becomes filled with fat. So they this macrophage is we term as the foamy macrophage. Okay, so let's see the questions. Dermal calcification deposits, no, because we cannot see any hardened surface. We cannot have any indication that the patient is suffering from any chronic inflammation or any condition like hypercalcemia. Foamy macrophage, yes, it could be the answer. Hypertrophic scar tissue, no, because usually hypertrophic scar tissue can see after a trauma or after a surgical procedure. And multinucleated giant cell we can see in chronic inflammations. Smooth muscle hyperplasia cannot look like this. So our answer is foamy macrophage. So let's move to the next one. A 32-year-old woman from Africa present with a 4-month history of the swelling of his right leg. Laboratory studies demonstrate a parasitic infestation. Soft tissue swelling of this patient's leg was most likely caused by which of the following condition? So it's very common. Imagine, I think you know about the this condition. It's called as Elephantiasis. So they're indicating toward a parasitic infestation. The parasite usually cause this problem is a filariasis worm, and once the patient is infected with filariasis, they used to tend to move to the into the lymphatic system. And in this condition, you know what happened, once it infect into your lymphatic system, it go up and block the inguinal lymph nodes because of the infiltration and necrotic process, necrosis of the lymphatic lymph nodes, inguinal lymph nodes especially. So once there will be damage to that of the lymph nodes, then the lymphatic flow will compromise. They start to accumulate here the fluids, the extravasation. Normally what happened, this is the blood vessel and this is the lymphatic drainage. So normally there will be extravasation of blood, the fluids and proteins as well. So their uptake and into the systemic circulation, the venous circulation, again by the lymphatic way. So once there is occlusion or the obliteration or damage of the lymphatic system, the extravasated fluid, they cannot enter into the lymphatic system, so they start to accumulate into the interstitium, and the area seems like swollen as in this condition we can see. So here It's the accumulation of the interstitial fluid because of the obliteration of the lymphatic system and because of the filariasis, and this condition is called as elephantiasis. So what is the answer? Congestive heart failure, there is no history of that. Deep venous thrombosis, there is no history of deep venous thrombosis. And kidney disease, it's not a kidney disease. Liver disease is not a liver disease. If it be, then it could be bilaterally affected, not only one. Lymphatic obstruction, yes, it's a lymphatic obstruction. The last question of today's is, a neonate has a well-demarcated lesion in the upper eyelid and forehead resembling a tumor as shown in this image. A biopsy shows the large vascular channels interspread with the small capillary type vessels. What is the appropriate diagnosis? So if you studied about the vascular pathologies, there are different type of vasculitis, like large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. So this is a type of the small vessel vasculitis, and that is what we call as the cavernous hemangioma. Why it is called as the cavernous hemangioma? The question itself is saying that there is a tumor-like mass we can see here on the patient's upper eyelid and the forehead side, and they're saying that a vascular channel, large vascular channels, biopsy showing interspersed with small and capillary type vessels. It means that there is a cavernous, like in any cavities like this, and these cavities are interspersed by small capillaries. So it's a type of a benign, you can also say like it's a congenital hemangioma. It's a benign lesion with large vessel channels frequently interspersed with small capillary type vessels. So these are the capillary hemangioma, the tumor of capillaries, and these spaces, they are called as the cavernous. So it is a cavernous hemangioma. So, and this sign is called as port wine stain. Okay. And sometimes we can also see the involvement of the hemangioma. The hemangioma can even penetrate or enter into the cranium or into your brain. So the correct answer of this question is a cavernous hemangioma. So thank you.